So movement, mobility, physical activity is very important for our mental health, for our physical health both. Social isolation, a big risk factor for developing this dementia in people who already have other risk factors. Please see around yourself any, members of the community who did not show up for last couple months, and we did not see, we do not know how they are doing at all, what's happening to them, so if some setback happened to them and then they withdrew away from the community, it's a big red flag. Try to bring them back, try to give them a call, try to make sure that, social isolation is, I cannot tell you, in COVID, when seniors had social isolation, they couldn't come to, lectures like this, or, come to Salat for, there was a big decline in cognitive activity, post when we did their MOCA testing, MMSC testing before COVID and after COVID. So keep yourself socially involved. And this is, alhamdulillah, our masajids have all these opportunities, so we should avail that. So, give yourself a pat on the back for being here and for being socially active, and keep an eye on people around you also, please. Okay, let's talk about early signs and symptoms of dementia. Memory loss that disrupts daily life, that, forgetting something to the extent that you are not able to complete your work. At work, it's taking you much longer, and you are concerned that, this is what I used to do, this program I'm used to at the computer, why I'm not able to, getting more help from the family members or the colleagues. It's a big change that somebody would notice. And please know that if it happens every now and then, here and there, with all the advancements, that's all normal. We are talking about that something that you were able to do before without any problems. Challenges in planning or solving problems, just like, some recipe that we were used to, and suddenly I started making something and I'm like blank, totally blank. That, it's something that's your second nature, or driving that, you used to go to the giant 10 minutes away from home, and suddenly you are like, where am I? And where is this giant? Why did I come out? For what? Difficulty completing a task, same thing, that same tasks that we were able to, like bills, paying bills. It becomes harder to, navigate through the process of paying bills that was not a problem before. Confusion with time and place. Sometimes, suddenly patient is like, where am I and why, how did I end up in this mall? No recall of you drove to the mall. Or, season has to do, ask, oh, okay, it is winter time, things like that. So you can see how normal and abnormal are, there is a line. Okay. Trouble with visual, image, or spatial relationships, that will come with driving. More tickets. Patients are like, I'm getting more tickets, or I crossed the red light, I didn't mean to. So, or depth perception, those little fender bender accidents. That's another talk of, what red flags to look at in driving, and, when to make a decision about that. So those things will happen. And then new problems with words. It's not just, forgetting the name of a person, or forgetting, but saying, like, for example, watch, trying to say the word watch, but it's not coming. You know that what it is, but it's not coming. So you'll say something like hand clock, or so this is just an example to say that, you make up for it, you know what it is, but the word doesn't come. Misplacing things and losing ability to retrace. Sometimes we misplace things and, we find them, sometimes we don't. But this is ongoing. It's like, keeping a remote control, when putting it away, keeping it in the fridge. I'm sorry, it happens. So they need to, but for the person, he has put it away. Okay, so those are the signs, and the family notices it and all that. I'm going to repeat this, that it's a big for not for the patient, but the people around, the caregivers. It's a big change. It's a big stress. They don't know what to do and where to go. So that is a talk by itself, and I would love to do that talk next time. But right now we are focusing on the basics. Once we know these basics, then we can go dive deep in. Um, Decreased poor judgment in terms of, didn't feel like taking a bath, poor grooming, and with the scammers, everybody has their own history of, problems with scammers. But something big, very obvious, and that's what scammers do. They look for elderly people with possible cognitive deficits and get their information and make them broke and, all that stuff. So every now and then, it can happen, but not very obvious like this. Withdrawal from work or social activity because they are not able to complete that task, and it's such a challenge. It's not comfortable for them to go back to it to do it. So then you see this withdrawal happening. Whether it's at work or in the social environment, that less activity, or there are people who were like speakers. What do you call it? In church, people come from church and they say, I cannot talk now. My audience want me to talk, but I cannot. I can just read this passage to them or something. So, okay. And then changes in mood or personality. They may become irritable, they may become withdrawn, sad. You'll find them crying more than often. They may become more anxious because their mind is telling them that wherever you are going now, you will not be able to keep up with that conversation, or all that. So, and they may become, they can be behavioral irritability, anxiety, sadness, all that, depending on the situation can happen. Okay, so I'll quickly talk about diagnosis. So when you see that your loved one, there are some red flags like that and all, do talk to the primary care. The diagnosis can be made by the primary care. It doesn't have to be a specialist. Primary care versus they can send you to a geriatrician if you want to. A psychiatrist can make that call, and a neurologist can make that call. Why neurologist? Because we want to make sure that this sudden change or a gradual change, whatever it may be, is it because of something else going on? Does the patient have a mass in the brain versus a bleed in the brain that caused it and remain unnoticed? Or had a mini stroke and the dementia is from that stroke that did not give any paralysis but did affect the memory? So all these things have to be ruled out. There are some blood work that needs to be done to make sure that is it all this forgetfulness from B12 deficiency, vitamin B12. If we don't eat meat, and people vegetarian or severe alcoholics, they can get B12 deficiency to the extent that besides other things that it can cause, there's the term called B12 madness. They present like demented person, and you replace that B12 and things change. So those are reversible things. We don't want to label patients with Alzheimer's when there is this thing going on. Or thyroid problem, you check their TSH, you check their B12, and those reversible things. So that's the job of the physician to take care of. So what happens is that there is, in this scenario, there is an interview with the family and the patient separate. There is a consultation, there's an interview with the family. There are certain questions that are being asked that tell us, is it real? Is it not real? How severe, mild, moderate? Where does it stand? And then which living situation they are in. Do they even have help? Are they in a good normal social setting, or it's all disruptive? So there's a very extensive history that's involved. We have to ask questions about memory. We have to ask about instrumental activities. Instrumental activities means driving, paying bills, cooking, cleaning, all that stuff that they were used to do before, car washing, so all those questions are asked. Then we have to ask about, their moods, any hallucinations, because there is another dementia, that is Lewy body dementia, that presents with visual hallucinations. I'm seeing children under my bed. They are not disruptive, but they are there. Oh, somebody came and did this, and and then left. So then you think about Lewy body, that develops Parkinson's, and it's a separate kind of dementia. That's why we ask about that. Um, so once the diagnosis is made, it's a huge, change in the life of a patient and the caregiver. So you don't stop there. You don't give them a prescription and go home. You have this, and you take this, and you go home. Then, in a proper setting, John Hopkins has excellent dementia program. University of Maryland has excellent dementia program. Kaiser Permanente has excellent dementia program. Anybody who has Kaiser, you can talk to your primary care, or if for your loved one, they, to let them know that there is a memory loss. There is an hour-long pediatric evaluation. Prior to that, there is an intake of, by a nurse. So there is a whole big system, so that there is we need a lot of hand holding in this diagnosis. So not just giving a script and go. So there is memory and there is function. They both get affected. So we have to take care of the memory, how we can improve, how we can keep them engaged, plus the function. Do they need occupational therapy for the falls that they are having, or gait training, because mobility is so important in a patient with dementia, because it's the mobility that differentiates between mild, moderate dementia to severe dementia, when the patient cannot move and they are bedbound. So to differentiate between that, we have to maintain mobility for as long as we can, so that we don't see the complications of immobility or non-ambulatory status. We delay it. If the patient has to live for 100 years, and we delay it so much that the immobility comes at 105, so we never saw it. That's why all these things are so important to, get the diagnosis, and then do what can help with the management. Okay, this family history we talked about is important. So all this is in that consultation. And then I'll just go over the 7 stages of dementia. I touched on it a little bit, that, initially, yes, there are some loopholes and there are some red flags that family noticed, patient noticed, but patient is still able to continue their job, or, are able to do their social interaction, everything. There's some slowing of some work, but it's still there. Then comes interruption in work. Then comes noticing of, the neighbor noticed it, or another family member, extended family noticed it, community member noticed it. They themselves notice that it's becoming harder and harder. They are not able to complete something, And then comes, behavioral changes with it that we have to keep an eye on. It is part of the process of moderately severe cognitive decline. And then their instrumental activities get affected. When their instrumental activities get affected, what are instrumental activities? Again, I'll repeat, instrumental activities are the ones in which we use our higher brain way more. For example, paying bills, taxes, the process of doing laundry, the process of car washing, the process of medication management. Now they don't even know the name of the medicine that they have been taking for years. So that all is instrumental activity. Driving, cooking, so that gets affected. And then their activities of daily living, which means walking, going to the bathroom, transfers, feeding themselves, they start getting affected. So that is our severe stage. Okay, so I touched base on it. We want to make sure that they are not taking any wrong medication. We want to make sure that their blood pressure, their blood sugars are managed decently. We do these labs to make sure that we are not missing out on something that is reversible, treatable. We do imaging to make sure that there was no stroke sitting there, or any bleed sitting there. Something called normal pressure hydrocephalus, in which there is a triad of that the fluid in the brain is so much increased and they have urine incontinence and their gait is wide based. It's very typical. People who walk in, you can tell, they walk like this, so it's something that can be treated. They can put a shunt, they can remove that fluid, and some things improve, some things don't, but you have to address that by doing the imaging. And then we do the cognitive assessment tests, which are very sensitive, that even if other person did not notice and I have problems, it will show on that testing. So we score it and we match. The score is the last. The family history from the patient, history from the loved one who accompanied the patient holds more weight than what they do on the test. So you have to match those things. And if there is discrepancy, then see where is the truth. In terms of some people, there are a lot of lovely ladies, who are immigrated here a few years ago, and they cannot do well on tests, but in their own little world, they are totally independent. They are cooking for their family, and they are doing their little voluntary work and everything. But in the test, the score is 5 out of 30. No problem. They don't have dementia. So that's why you have to, look at the whole picture. Okay, the management includes that, for every patient, there is a different management. It's a one size fits all does not work here, because, they have their own social aspect, they have their own, what individually they are dealing with, what the caregiver is going through, whether they have insurance, not insurance, so you have to look at all those things. A caregiver support is a big thing, and a different, topic that needs more elaboration of, what support resources we can use. Management, as I said, there is no cure, but there is treatment. And you might have heard the names Erisef, Namenda. These medications are out there for a long time, and relatively safe medications. They do have a set of side effects that we follow them up for the side effects. We do a 2-week, 3-week follow-up with the nurse, and they go over all the side effects and how to manage them, just like any medicine, but nothing, drastic. It's usually a pretty well-tolerated medicine. What do they do? What do these medicines do? There are no magic pills. These are not magic pills. The patients may say, but there was no change in my memory when I took those. What they are doing is they are delaying, in some patients, they are delaying the progression. So what they have not seen in future, that's not happening now. So that's how they are helping. It's not that they'll wake up and they'll feel better. Actually, Namenda helps with the mood also, and they do feel better. Sometimes it helps with, the behavioral aspects of the patient. These medications help with the behavioral aspects of the patient. They may not change the memory, but they are slowing, in some patients, they are slowing the progression. So it's a protective layer, good to have if you can tolerate it. New medications, I'm going to talk about, because you might have heard on, seen all these ads on TV, the new treatment for Alzheimer's and lecanemab, donanemab. What they are doing is, I'll just try to concisely talk about it. What they are doing is, I talked about those gunk proteins that are interfering with the nerve signals between those brain cells. They decrease the burden of those, they decrease the amount of those proteins. Okay, very fascinating. Wow, they decrease. But what's happening is that people who, the research, the study was stopped after 18 months. They did not even complete the study, and it was FDA approved. So the data is not what will give me the decision to give this medicine to my loved one. I'm not saying. We have patients in trial who are in the process of getting this medicine, but we talk to them that the side effects of these two medicines could be little hemorrhages in the brain, swelling of the brain. It's an infusion that you do every 2 weeks or so. You do need MRIs, sequential MRIs, to make sure that the medicine is not causing other damage in the brain. And in the end, I would rather have patients on better social support and better cognitive exercises than going through this unless things change in future. So they don't take my word. I'm saying that there are patients in our, database that are being examined to, and there's a big exclusion criteria. If they had stroke, they don't qualify because the dementia could be from stroke. So there's no amyloid, or not much amyloid to decrease while giving all the side effects. So that's a little bit about those medications. Hopefully there'll be better avenues, better outcomes, better choices in the near future. But this is, a big start, a big jump, a big change in the management. Before that, we had this Aricept and Namenda for a long time. We are still doing it. And very important is monitoring and follow-up. As I said, it's not a prescription that you go and leave the patient. You can ask your physician that you do want to see them every 3 months, every 6 months, and you do want them to be update them with any changes and all. And sometimes, new things emerge and some changes happen, so it does need modification. Sometimes behavioral changes happen out of blue. So you have to be in touch with the physician. Okay. Okay, one very important thing, advanced care planning. For us living in this country, if we didn't say it or if we didn't write it, it didn't happen. Okay. So people who are losing their ability to make their decisions, we have to ahead of time decide. We all should decide. We don't have to be 70, 80, 90 to decide all that. We have to decide now that in this country, if things happen to me, do I want to have CPR? Do I want to have dialysis? Do I want to have a PEG tube if I'm not able to eat by mouth and all these are? And if you're not sure about that, leave it that blank. But whatever you are sure about, it should be written down somewhere. Those are called advanced care directives, advanced directives. You are telling in advance what your direction is in case things happen. So it's very important that we all should have it, and especially if people have cognitive impairment and all that, they should take care of that so that things do not happen that they don't want them to do when they are not able to make the decisions. So there are ways to do it. There is Maryland Order of Life Sustaining Treatment, and it's very simple than what it sounds. If you make up your mind to do those advanced directives, then you can check with your primary care, and they can assist you with that. And who is your healthcare agent? Who to ask, and if there is some friend that we are not even aware of, and it's not even written anywhere, in case of emergency, who's going to know who's that friend? So some of those things to be written down. Physical activity. Okay, cognitive exercise. This is extremely important. So there is a triad. I tell patients that first thing in management of your loved one who is diagnosed with dementia is to see if we can have first to understand what it is. And I'll highly recommend anybody who is going through this to a loved one or something to go to alzheimers.org. It is an excellent website for understanding what Alzheimer's is and what is the next step. So educate ourselves is the first step, and understand that yes, this is the diagnosis dropped on us, but there's so many things that can be done, and build a routine. Okay, build a routine. Routine is always important. Don't let the patient be on their own. That okay, some days they are waking up at 2 p.m. Other days they are waking up at 8 a.m. Some sort of routine, not very regimental, but some sort of routine in which in that routine we should have cognitive activity, physical activity, and attention to nutrition. Okay. Physical activity does not mean to join a gym or anything like that. Physical activity means that you do a 15 minutes, depending on the patient. Again, it's an individualized plan. For one patient, it will be only 15 minutes, good enough for him or her. 15 minutes of brisk walk. Weather is bad, don't worry, do it around the table or go in the hallway, from the room to the kitchen. Put the timer on, because that mobility, again, is saving them to go to the severe part of dementia. in years to come. I didn't mention that, but since the diagnosis of dementia, when you will get, researchers have said only Allah knows. Researchers, show that it's 4 to 8 years. It can be 20 years, depending on if there are no other medical problems and things are perfect. We are doing all of this, then it's longer. But usually that's the case. So physical activity is that way important. And cognitive exercises. Cognitive exercises is anything that is of interest to the patient, but it has to be structured. It has to be, on a daily basis, whether it's Eid or whether it's, any regular day like today, but make sure you do your cognitive exercise before you go to bed. What's, for one person, it will be memorizing one ayah of the Quran. That's an excellent cognitive exercise. You are using all your faculties to try to memorize that ayah, and all your, neurons are talking to each other because they are trying to memorize new information. It's an excellent way. Whether it takes you 20 minutes, or 30 minutes or whatever, this is an exercise to do. If you are, if a patient is at that level. For other people, it's playing crossword puzzle. For another person, it's word search. For another one who is not that literate, jigsaw puzzles, 50 piece or 20 piece or 30 piece. So make sure that they have a half an hour of physical activity, whether that is on chair, they are doing some exercises, or they are walking that, and then cognitive activity half an hour, whether you split it 15 minutes and 15 minutes, and then I'm going to give all this to everybody later, but I just want to go over this. This is an excellent program called Stronger Memory. It's taken out of research from Japan, a long, very detailed research. The person who applied it here in US applied it first on his mother. And he, in 30 days, the difference that he saw, he is now started this big program of Stronger Memory, system, in which it's very simple actually. The best part is that it's simple. 30 minutes each day. Again, we have, I want to repeat it, we have other ways of our cognitive activity. If we sit with Quran, we don't need anything else. But if you want to add something, here, it's all very structured. So what is it? 30 minutes of exercise, 10 minutes reading out loud, as if you are reading out, like I'm talking to the audience, but I'm reading it. I'm saying the Stronger Memory workbook includes over 100 pages of simple math problems, as if people are listening to me. So that is 10 minutes of read Quran, 10 minutes loud, and then back to your own pace of, whispering, talking for one point in your own way. But that 10 minutes when you are reading out loud, the connection of your brain with that voice is doing something here. Okay. Then another 10 minutes is writing by hand. Whether you write something, you are in a course and you are asked to write something, you are, learning about Ramadan, you want to make a journal, a nice journal with a nice fancy pen, every day you sit and you write, 10 minutes of writing. So that's right. And it's not about typing, it's about writing. Back to the basics. So you want to write. Typing is not going to do what this is going to do. So writing, and in this, you all will have it. It has, and please pass it on to other people also. The website has PDFs that you can print out. So it has writing prompts. My best memory from the past, or what will be my ideal vacation? If I go back in time, what will I change? And you pick one and you write 10 minutes. Okay. The last is doing simple math. Again, this website has all these worksheets. No, this you can look at it, but this all is printable. Stronger Memory Program book is printable. So anybody in your family or in your community that can benefit from it, give them the website. They can print it out. give them this. You can, all take a copy of it. That it's a very structured thing. Sometimes we give them all these links and all. Nobody goes back and look at those links. So this is something to give, and actually it gets done. Next time patients come and they are very happy that we were able to do all that. And I tell them that when you see the math sheets, they may look like, oh, this is very simple, I can do it. It's not about that. It's about going through that drill and that process of doing it. Okay, I'll briefly touch on the resources. If we have to pick top 4 resources for Alzheimer's, one is, this Greater Maryland Chapter Alzheimer's Association. Alzheimer.org is everywhere. If you try Google it, you'll find it. And very nicely done about general education. And if I'm diagnosed, steps of caregiver, what are the resources? So very well organized. And they have 24/7 service. You can call them anytime. This is my problem, and they'll connect you. They are pretty receptive. Maryland Department of Aging and National Institute of Aging, both. We have some pamphlets and some information from National Institute of Aging, that you are more than welcome to take with you, of general information and resources. Then John Hopkins, as I said, somebody has good insurance and knows that, wants to be evaluated, then do that. And if you don't have insurance, don't give up, MCC clinic, ICM clinic, and, you can talk to them about that. This I'm not gonna, okay, Department of Aging has all these, what's written here, it has everything there. So whatever is relevant to you, to your need, you can click on that and do it. Okay, how much time we have, Sister Panita?
We have the Salat al-Dhuhr is 1:30.
Okay, so I'll try to finish. I wanted to focus on this after all that we discussed is for all of us, what to do, how to prevent, and how to decrease the risk factors from something that has not happened. So our body is an amana, and we will be asked about what we did for it. So besides taking care of our general health, being compliant with our medications, getting our regular checkups from the doctor, and understanding what we have. Some people, they say, oh, I have little sugar. So, and it's fine now. So I want us to be more aware. It could be, it could be a physician also saying the same thing, because it's the denial process, Our body does not want to know. 10 minutes, okay. So, so awareness and taking the responsibility, doing our dua, doing our sadaqah, and doing our job of and the actions. So let's talk about some of the actions in 10 minutes. Okay. I wanted to pick some pictures for us because picture can speak more than words or whatever. So see, 20-minute walk. This is the brain on the left side, sitting brain or on the couch watching TV, versus the brain after 20 minutes of walking. How lit up it is and how the neurons are all active and awake. Okay, so we can include, please make sure we all are busy. We all have reasons not to do physical activity, but make it like, make the niyyah that I want to take care of this body for Allah subhanahu wa ta'ala. So I have to take out 20 minutes. And do your askar in those 20 minutes, the 100 tasbihat that we wish that if we had time, brisk walk and do those tasbihat and do those askar and do the dua, do the review of your surah that you know. So, or just do tafakkur, all that around you. And if the weather is bad, I said no excuse. What we can do is on YouTube, we can put walking at home. And they make you walk at home in this little circle, walking in place, walking to the right, to the left, and in 20 minutes you are done. Sometimes I tell my patients, if somebody talks too much in your family and they call you, as soon as they call you, you pick up the phone and start walking. And by the time you are done, your exercise is done too. So, these exercises are increasing the blood flow to the brain. And all this dopamine and all these good transmitters are being released for the better function of the body. We don't want the false dopamine spike by all these sugar intake. We want this kind of dopamine release where all this neuronal activity is increased. Strength, so this is our walking part, right? Strength training. Strength training is not anything that athletes do or active people do or people who play sports do. You and I should do it too. And how? I'll tell you one example and you can make your own plan. It just needs less than 10 minutes to do. Our main muscles are our lower body, our legs and our arms. So if we do our legs and arms, and if you have more time, you can add your core. So what do you have to do? Just, we have a program with some of our friends. After every salah, we just spend 3 minutes only, okay? And if you cannot do after every salah because you are at work or something, 2 or 3 salah, 3 minutes. 3 minutes in which you do 15 squats. If you cannot do 15 squats because of the knee problem or something, look for modified squats. 15 push-ups. If you cannot do that, don't worry. Do the push-up from something elevated like this. This is your push-up. Don't think about the push-ups that are being done on the floor. You are missing out on so much by not doing what we can do. So always look for modified. If these terms intimidate us that, oh, I cannot do push-ups, always look for modified push-up. Everything is on the internet. But don't get overwhelmed. Make your plan, 3 exercises that I'm going to do, modified plan, modified squats or sit-ups, or there's something interesting I'm going to tell you that you can look up yourself on Google and I think you will like it. There are a group of physicians who started this, that it works, this kind of exercise is equivalent to doing 40 minutes in the gym. You do 3 minutes 3 times a day. See, that is my exercise for the day, what you are doing. So, this is called nitric oxide dump. The name is fancy. Basically what it means is that you are releasing all this nitric oxide into the blood vessels that dilate the blood vessels, increases the blood flow, and you are getting all the benefits of doing like 40 minutes in the gym, with the gym membership, that you go maybe twice a month or something. So it is 4 sets of things. It's arm raises, it is forward swings, it is arm swings, and it is squats. These 4 things, what are we doing? We are covering all the major muscles of our body. You do in rapid succession as safe for you, whatever is safe for you, 10, 15, 20. The guy on the YouTube will tell you, and you make your own program, and then slowly build up, and 3 minutes only, and then you did your exercise. If you haven't done an exercise in months, these 3 minutes will count as today you did your exercise, done. Okay? So that is physical activity that we want to work on. Then next thing is, which exercise is the best? Do we have an answer?
Wrist walks.
Yes, excellent exercise.
Whatever is consistent.
Salat is very good.
Salah is not an exercise.
But my point is, the best exercise is the exercise that is actually done. We can make plans for different exercises, but start with basic and be consistent, like our Prophet ﷺ said, small things, consistent things, very dear to Allah subhanahu wa ta'ala. So point is to make a program and stick to it and modify it according to your needs, but don't give up. Continue to do it. It will all add up. It's all additive effect. Okay, so the physical exercise, basically it's increasing our cognition, it's increasing our physical fitness, it's increasing the risk of dementia by all the things in the middle. There are changes in the white matter, gray matter, there is neuroplasticity, which is, we can talk about another time. So that's all happening. I cannot lay more stress on this. Then make sure that we are not socially isolated. There is no untreated depression. There is adequate sleep. Talk to your doctor if you have problems about melatonin, which is a very natural chemical, and in the right amount, at the right time, with the right sleep hygiene, not like you took melatonin and you are on phone. That doesn't work. All lights off, all screens off, eyes closed like we do to babies, and then we fake it until it happens, the sleep. And then make sure the sleep apnea is treated. If you have any concern, get yourself tested. Spiritual well-being, alhamdulillah, we have many ways of being spiritually well. Social well-being, we are all here in the social and in such productive, positive environment. This is all very therapeutic to the brain. Gratitude journal, people talk about, we start with our day with shukr, we end our day with the shukr, alhamdulillah. We can always write, the list of things that I'm thankful for to Allah subhanahu wa ta'ala that, is specific to today. 10 things. Every day you'll find new things, of course, and more than that. Nutrition, there's not enough time, but all I can say is you can look up Mind Diet. All we are talking about, less processed food. Less processed food means, easy thing is that we tell our patients, if our grandma looks at our plate, she can recognize what we are eating. If she cannot recognize what we are eating, it's all processed.
Yeah, after the salah.
So, Mind Diet, we are talking about whole grains, legumes, beans. We are talking about nuts and seeds. We are talking about salmon, which is the oils of salmon are excellent for the brain health. We are talking about olive oil. So all that, fruits and vegetables. Our plate should have more vegetables, some protein in form of plant protein. If you like your meat, why not? You can have that. Whole grains and basically avoid sugary stuff, processed food, saturated fat. What's happening with all this is inflammation. That inflammation goes to the heart, causes heart attack. That inflammation goes to the joint, causes arthritis. That inflammation goes here, causes dementia.
A question about the saturated fats.
Yeah.
Some of them are good for you, actually. Like
Some are very good, absolutely. Animal fats, yes. So animal fats are way better than vegetable oils. Vegetable oil is a misnomer. Please take out any vegetable oil in your house. Throw it away. It's worth throwing away.
It has no vegetable in it.
Yeah, there's no vegetable. There are trans fats in it, which is, ghee is way better than, the processed oils, canola oil and vegetable oils. That's like the brother is saying. So we are talking about saturated fats in excessiveness and too much fried food and in that regard. But if you have to choose which saturated fats you want to use, the animal fats, the ghee and olive oil, the grapeseed oil, avocado oil, coconut oil, top of the list. Use it in moderation and yeah. Okay. Engage in lifelong learning and mental stimulation. Again, we talked about this, right? All these games, you can Google you can pick your game. Sometimes we used to play board games when we were little. You can come back to that. Or, start a memorization program, start a tajweed program, start, tafsir program, anything that will stimulate our brain. Okay, this is my last slide, 2 minutes left. If we can, the takeaway message, things that will improve our brain health is social activities. That I think all that are here in under this roof are doing that. Nutrition, we touched briefly on it. Mental stimulation, cognitive exercises. We can, our manual, our Kalam Allah is the perfect way of getting that mental stimulation. Stress management. Stress is for everybody, right? There's no reason not to be stressed. But the difference is how you manage that stress, how you navigate through it, how you displace it by doing other good things. When you have the worry of Quran, it's better than having the worry of, who's coming to my house, what will I wear and what will I cook and all that. Exercise, we talked about that, and sleep hygiene. that's about it. And, if you have any quick questions,
I do actually.
yes, please.
You stressed Quran memorization, interpretation, listening to it, all of that. Actually, there was a statement to Abdullah ibn Abbas that actually echoes that. He said, whoever memorizes or recites the Quran frequently will not suffer from mental retardation. So I was just wondering if there has been any studies done on that.
There has been study in memorizing the new language. And in that study, there was a Muslim physician who did on Arabic. So it's not directly on Quran, but it's about learning a new language. So alhamdulillah.
Not a question.
Any other questions, please?
I just need to give an announcement.
How late in one's life can you get diagnosed? So,
How late? You can diagnose, dementia is, Alzheimer's is more common after 65. So if you have symptoms, if we consider somebody has symptoms, then they can get the evaluation for that. More than 65. Less than 65, it's very unlikely. I was talking earlier that it's still 1% genetic causes that cause it. Unless patient had a stroke and got memory problems after, that is the stroke dementia. That's not Alzheimer's dementia. That's a little different. It's a step ladder pattern, behavior, erratic behavior, irritability, anger, family notices, and everything started after. That is early. But regular dementia happens after 65.
can you not be a chef, so you still have time.
Can I ask you this question,
Yes.
please? You had mentioned that there is a monitor you can put on your chest that your health provider could give you that. Could you remind us the name of it?
Okay, so this is called sleep study. Okay, so this monitor is done by sleep lab, and your primary care, your doctor will refer you to the sleep lab to get the sleep study done.
Because the Azan was given. Yeah,
Well, okay, well, we're supposed to,
We can
well, then
discuss here.
stop everything at the Azan
Let
and let's
the-
go pray and
Let the doctor
because
finish.
this is a very important question, I think, I'm asking.
Sure.
So we want to record it, and which is the provider? I have about four provider that take care with me.
Okay,
You mentioned the health provider, the heart provider.
Yeah.
But there is another provider, urologist, I think you said? No?
neurologist.
Neurologist, okay. So, you see, so
Yeah.
I want to make sure.
Yeah.
Well, my better half, guys, I know she not a recorder, but she recorded it right now.
Okay.
So,
So to answer your question, your primary care physician who takes care of your general health will refer you to the sleep study. And they have different groups that they are, connected with. So they'll say, okay, you will go to this doctor or this sleep lab to
yes.
get
and
your
do this
home sleep
procedure.
study done. And, all insurance based and all that, but, if you are going to MCC, you can ask, about that. Yeah.
Okay, thank you very much.
Sure.
One last question, I might have missed the remark, but is it hereditary?
Hereditary.
Okay, there is one type of dementia which is called autosomal dominant Alzheimer's disease, ADAD, which is hereditary, in which 50% of the family members have it, and they start at 30, 40, 50. So that is hereditary, that is less than 1%. The other part is there are genes that give you increased risk, but do not give you a diagnosis that yes, you will have it. But those genes do not need to be tested because the guidelines do not recommend for any and everybody to get tested for that unless they are very specific. For example, President of USA has dementia and they check the genes and the both alleles of ApoE4 are positive, then they have to do something about it. Otherwise, no gene testing. It's only for families that have it. And yes, there is a component which is very, very, less percentage that has the hereditary component. Other people may have the genes, one allele versus two allele, but, we don't test for it. Yes, please.
Oh, wow.
I have many questions for you, but I already forgot the whole of them.
You want to talk about the subject of.
Yeah, I don't think it's a joke, honey.
My wife
It's
always
not a
tells
joke.
me I'm crazy.
She's right.
Oh, yeah, sometimes. Now, if I go home, I want to explain what something about this conference here. What will I tell her I have? Is it Alzheimer or dementia?
You have normal aging.
Thank you.
But I said, if you want to discuss with your wife and all, Alzheimer.org is the best, Alzheimer.org. I can write it for you.
Thank you.
And that has, for, understanding of what dementia is and when to get evaluated.
Before you leave, lunch will be served after we pray. Come back up, we'll have lunch for you, and also don't forget your ticket, because we have 5 people that will get a surprise. And we do thank you, doctor, it was very informative, very informative.